Hello everyone, how are you all? So this is our second class on cardiology. So we finished our syncope cluster 2 days ago, right? So I hope you guys also tried to finish the syncope cluster and also you guys had some benefit from the last session. If you guys have any question on the last session, you can obviously ask it today so that we can go through it again if there is any problem anywhere. So tonight we are going to finish the cardiology if possible. So the main other two clusters that is left in cardiology is your palpitation cluster and also chest pain cluster. Both of these clusters are very commonly asked in AMC clinical exam. So you should have a very good idea on it. Now, as you already understand that we follow a cluster-wise approach for all these classes. So tonight cluster will be palpitation. So for all cluster, we usually start with a differential diagnosis, and then we go through the history and the relevant physical examination, and then we go through the cases that is related to that cluster. In this way, it becomes very easier to finish a lot of cases in like single format. That's the reason of doing a cluster-wise approach. So let's start. So we finished the syncope cluster. Let's go down. Okay, so this is the palpitation cluster. Now remember one thing, the palpitation cluster also similar to the another cluster called the nervousness cluster. People can come to you with nervousness, feeling anxious, feeling unwell. So all these things will also fall under nervousness cluster. Now the differential diagnosis of feeling nervous also falls the same differential diagnosis as of palpitation. So anytime palpitation or nervousness, any of these two comes, the format is same. So what are the differential diagnoses of anyone coming to you with the feeling nervousness or having palpitation? First of all, obviously, if palpitation is your cluster, you should always start with the CVS. In CVS, any patient coming to you with any cardiac related causes or cardiac related symptoms, all the time try to rule out ischemic heart disease or myocardial infarction. Also, it could be any arrhythmia. That's our main causes of any palpitation. So arrhythmia will include everything, which means your atrial fibrillation, flutter, SVT, every arrhythmia will fall under the same thing. And sometimes even valvular diseases can also lead to palpitation. So for CVS, we have ischemic heart disease or MI, hypertension, arrhythmia, valvular disease. Then the next one is CNS related. All those CNS related causes not basically cause palpitation, rather they cause nervousness, but still you can ask CNS related causes in the differential diagnosis of palpitation. So always I say that for any CNS, four causes are always there: trauma, tumor, infection, stroke. So you can remember trauma, also you can keep tumor, infection, stroke, and sometimes epilepsy as well. After severe CNS, then you have endocrine related causes. Very important is the endocrine related causes, especially your hyperthyroidism, hypoglycemia, and pheochromocytoma. These three are very common to rule out. Anemia sometimes can lead to palpitation. Anxiety disorder is another important differential diagnosis you should always rule out. So patient with anxiety disorder or having a panic attack or any stressful condition can lead to palpitation. Another important is menopause. There is a lot of cases came in so far with just feeling nervousness, feeling anxious, and turns out that was a case of perimenopausal state. So menopause, if any female patient come to you with feeling nervousness, feeling anxious, or having palpitation, especially around 45, 55 years old, you should always think about menopause at the first few diagnoses. Excessive tea, coffee, and recreational drug. Also very important to rule that out. Sometimes SVT, mainly supraventricular tachycardia, has some underlying risk factor for those patients who take a lot of coffee. So it's important to rule that out. Then some of the recreational drugs like MDMA, methamphetamine, they can cause palpitation. Medication induced, especially salbutamol, like a patient with asthma COPD taking salbutamol inhaler, and they can present to you with palpitation because that's a very common finding. So medication induced is also one of the important one. So you have to remember this palpitation differential diagnosis before everything. So CVS causes, CNS causes, then we have endocrine causes, we have anemia anxiety, we have menopause medication, and then we have excessive tea, coffee. Clear? So remember in this way, CVS, CNS, endocrine doesn't, now usually I used to do this. So C, E, A, remember carcinoembryonic antigen? So CEA, then just keep the M2. So CEA-M2 that you can use as a mnemonic. Now, I don't usually give my mnemonic to anyone because I think it's a good idea to use your own mnemonic because it helps you to understand or helps you to remember in the exam that this is my mnemonic and I can use it at any time. So remember one thing, try to keep some mnemonic in your mind for the important clusters. Like palpitation is a very important cluster. You should always keep a mnemonic in your mind so that even in the time of distress or a stressful situation like in your exam, you may get total thought block. And in those thought block, this mnemonic especially comes in really handy. So keep some mnemonic in your mind so that you can remember. So for C, we have CVS CNS. For E, we have endocrine and excess tea, coffee. For A, we have anemia, anxiety. You can also keep alcohol. Then M2, medication and menopause. Okay, so this is how you should remember. Now, patient with palpitation will always come acutely. So obviously you should ask about hemodynamic stability. I understand that most of you was in our previous session, so you should know how we start our conversation with the patient. So always try to reassure the patient like, well, hi, this is Dr. Arshan, one of the doctor here. I understand you are here because you have been feeling racing of your heart. I'm really sorry to hear that, but please don't worry. Now that you are here with us, we will take care of you and you will be comfortable again. Now, before I start asking questions to you more in detail, please excuse me for a moment. I just want to talk with my examiner and I will come back to you. Is that all right with you? Yes, doctor. So, dear examiner, now because now your exam is going to be most likely online. So, in here, there will be no examiner, there will be a case manager. So, whatever is written in the task, you will use the term. So, if it is the case manager, then you will say, dear case manager, I would like to know if my patient vitally is stable to go for further history. Okay, so usually in here the most important is to make sure that patient is stable blood pressure. So you should ask about the blood pressure obviously, and most important is the pulse. So pulse rate and rhythm. Rate rhythm will help you to understand, or like at least you should get to know that if this patient having atrial fibrillation or not, because if rhythm is irregular, that's most likely atrial fibrillation. So pulse rate and rhythm, you should ask specifically in here. So so you say that your vitals is very important in this cluster. So don't miss to ask vitals in this case. After that, then you come back to the patient and you say that thank you so much for waiting, John. Now, can you please tell me more about what exactly happened? So open-ended question. And then patient will say, doctor, I was just running or I was just jogging at the park and suddenly I feel like my heart is racing and I cannot even I was feeling very dizzy at that time. So then you say, well, thank you so much for your information. Don't worry, I understand it should be really stressful for you at that time. Can you tell me, did it happen suddenly or gradually? it started suddenly, doctor. Well, is it the first time it happened with you? No, doctor, it happened quite like 2 or 3 times before. So can you please tell me what exactly were you doing at those time when you had this similar type of attack before? So obviously we need to ask about the previous episodes, that how this palpitation is coming up. So anything makes it better, anything makes it worse. Is it continuous or on and off? And how long each episode lasts? Do you do anything to stop it, or does it stop spontaneously on its own? So that's important to know, that how long each of these episode lasts, and do you think like do you do anything to make it stop, or does it stop by its own spontaneously? So that's important to ask. And always we ask, anything makes it better, anything makes it worse. Clear? So that's your mainly palpitation question. Sometimes in your like Karen notes, there are sometimes they say that you should tap on the table to ask the patient, can you show me how was it? Is it like this, or I feel like this is a kind of like a stupid kind of uh, asking. Many, I have heard that many of the role player get really cranky when the when the candidates ask this sort of question. So you don't need to do that actually. So, and it becomes really confusing sometimes, and it kills your time in the exam. So tapping on the table to show you how was it is not important. So forget that. Okay, you're not going to fail for that. What can happen, that role player can get cranky when you say this sort of things. Clear? Now, after you ask the palpitation questions, then you always remember, in our format, we ask the history of presenting complaint first, which is the HOPC. Our HOPC is palpitation. Now, together, always after the HOPC, ask the associated symptoms. What can be associated with palpitation? Very important, palpitation associated with dizziness or lightheadedness. And sometimes it can be also associated with chest pain, shortness of breathing, and also nausea, vomiting, sweating. So all this question you will ask in the associated symptom. And remember that associated symptom also will cover the CVS differential diagnosis and also your CNS differential diagnosis. So let's see how you can do that. So during this episode, or along with the palpitation or racing of your heart, did you feel dizzy or lightheaded? No, doctor. Or yes, doctor. So if it is yes, then you have to say, well, did you fall or did you lose your consciousness? If no, then move. So any chest pain, shortness of breath, any nausea, vomiting, or excessive sweating. So that's yours mainly CVS differential diagnosis question, right? If you ask chest pain, shortness of breath, nausea, vomiting, excessive sweating, that's rule out any myocardial infarction. For CNS, any headache, any problem with your vision or speech, any weakness, or any loss of consciousness. So that's also usually cover your all the CNS related causes. So any headache, blurring of vision, any difficulty with your speech, any weakness anywhere, any loss of consciousness. That's your CNS related differential diagnosis. So you ask the CVS causes, you ask the CNS. Now, what are the other differentials are left? So endocrine. So for endocrine, we have hyperthyroidism. Always try to ask one or two questions for each of the DD. So any recent change in your weather preference, that's mainly for any thyroid condition, you ask the same question, like any recent change in your weather preference. Why you ask it? Because people with hyperthyroidism, they usually feel really hot and sweaty. So they usually prefer cold weather. Just the opposite happens in hypothyroid patient. They feel really cold, so they prefer hot weather. So that's why we ask any recent change in your weather preference, any change in your bowel habit, any change in your body weight. People with hyperthyroidism, they have diarrhea and they also lose body weight. So that's why it's important to ask. So change in the weather preference, change in the bowel habit or body weight. Pheochromocytoma, for pheochromocytoma, just one line. So any episodic headache, sweating, or flushing of your face. So patient with pheochromocytoma, they usually has these intermittent episodes of hypertension, flushing, headache, and also sweating all over the body. It's not a constant feature, it comes and goes. So any episodic headache, bloody headache, sweating, and flushing of your face. And another endocrine cause is hypoglycemia. So did you skip your meal today? Do you have any history of diabetes? After endocrine, what else we left with? Anemia, anxiety, right? And also electrolyte imbalance, infection that they can also cause palpitation. So for anemia, do you feel tired or fatigued these days? Anyone told you that you look pale these days? Just one question is enough. So do you feel tired or fatigued these days? No, then it's okay. Infection sometimes can cause palpitation, mainly if there is any high fever. So ask about any fever, any cough, any runny nose, any flu-like illness. Electrolyte imbalance, like if you are losing body fluid, especially excessive vomiting, excessive diarrhea, that can cause palpitation. So any vomiting or diarrhea, just one question. Then remember, we need to ask about anxiety, we need to ask about recreational drugs, tea, coffee, past medical history. So all this we will ask. So for then you can ask about SADMA. So do you smoke or drink alcohol? Any use of recreational drugs? Any so do you take tea, coffee? So if yes, then how much tea or coffee in a day? That's very important. Do not forget to ask about tea, coffee because it's very commonly associated clue in your exam. Then past medical history is very important. So any history of diabetes, hypertension, heart disease, any family history of sudden cardiac death. Very important question. Sudden cardiac death in the family is always important to know. Then social history. Remember, stress is one of the DD. So how is your so you can ask in this way, who do you live with? Any stress at your home? Any stress at your work? That's for stress. People with generalized anxiety disorder, they always feel palpitation because they worry about everything. So that's why you can ask, do you worry a lot about most of the trivial things? Or you can ask that, are you an anxious personality? So that's for generalized anxiety disorder. It's very important to rule out. Panic attacks sometimes can present to you with acute palpitation. In that case, you can ask that, well, at the moment, are like when you have the palpitation, do you feel that you are having choking sensation, you and also you feel like you are dying? Any previous history of panic attack or panic disorder? So that's an important differentials to rule out. So you can always add these things in here. So you can say that, well, at the time of your racing of heart, have you ever felt choking sensation, or you feel like you are going to die? So fear of dying is very common in panic disorder. Okay, or directly you can ask. So any history of panic attack or panic disorder. In that way, examiner will understand that you are ruling that out. And for female patient, especially middle-aged or elderly, you should always try to rule out menopause. So ask about like, when is your last menstrual period? If they say if they say like 2 years ago or 6 months ago, 1 year ago, then you should ask about menopausal symptoms, which means that you have to ask like any hot flashes, any frequent mood swings, or any dryness in your down below. That's for menopausal symptoms. If patient is still menstruating, then you don't need to ask about menopausal symptoms. Clear? So in your history, you will start with the reassuring, then go to the examiner for hemodynamic stability, ask about all the palpitation question, associated CVS and CNS question, then endocrine differential diagnosis, then you have anemia, anxiety disorder, you have medication, you have excessive tea, coffee, recreational drugs, sadma, then you also have family history, you have history of stress, you have history of generalized anxiety disorder, panic disorder. So all these you have to ask one by one. Clear, guys, about the palpitation differential? Remember, most of the time palpitation usually comes with differential diagnosis. So try to ask all these differential. No, rheumatic fever patient you is not like 5 to 15-year-old patient usually presents with rheumatic fever, right? So most of these patients will be more than 15-year-old who are coming to you. So rheumatic heart fever is not a like rheumatic fever is not your very important differential diagnosis in here. And it doesn't mean that like patient will have recurrent sore throat in here who Dr. MD. So it's not like that, that your patient with rheumatic carditis, they will have one sore throat, and that will lead to the complication in the heart causing pancarditis. That pancarditis sometimes can cause palpitation. Okay, but it's not like anything recurrent sore throat and recurrent inflammation of the heart. So it's very unlikely to be a case in the exam. And also it's a common in the young adolescents, like 5 to 15-year-old. After like if this all these patients usually come to you at 30-year-old, 20-year-old, not very important. So Dr. Fernando, the SADMA means, we usually in the SADMA there are a lot of things. It's a mnemonic, but for SADMA just remember S for smoking, A for alcohol, and M for medication. This D is for mainly diet, and A for mainly activity or allergies. Anything you can keep it. So mainly we keep it as a allergy, and D for diet. But don't ask it, it's not very important. Just smoking, alcohol, and medication history is important here. Pheochromocytoma, so as we have written here, so you can see that this is how you will ask pheochromocytoma. Patient with pheochromocytoma will come to you with a history of episodic headache, sweating, and flushing of the face. This is the question. If any of these things came as a positive, then you should think about pheochromocytoma. It's a very rare disease, so usually not in exam cases, so not very important. You are just trying to rule this out, but these are not very important cases. Always in the exam think that the common diseases are usually the important, because what are the common diseases? Hyperthyroidism is very common, hypoglycemia common, and any of the arrhythmia is very common. So usually we should always think in that way. Don't go into very deep or complicated diseases, because very unlikely that in the exam they will give you a case of pheochromocytoma, or they will give you a case of, like, what we can say, even ventricular fibrillation. Not likely. So always the common features or common diseases should come in the exam. Now, PEFE, after you finish your history of palpitation, go to the physical examination from examiner. So it's the same like the syncope cluster. The same PEFE you can also ask in the palpitation cluster. So for cardiac, the physical examination is same format for every cases. So general appearance, pickled, vitals and BMI. In the neck, you go for JVP carotid bruit, CVS inspection, palpation, auscultation, and then go to the CNS, and lastly finish with urine dipstick, BSL and ECG. So we discussed this PFE in the last class. So if any one of you haven't been in the last class, please go through that so that you can understand. It's not needed to discuss it again today. We will start with the cases now. Supraventricular tachycardia. Now these are the important cases. So supraventricular tachycardia, you are a junior HMO in emergency department. A man came in with a thumping or racing heart and giddiness started today. Giddiness, dizziness, lightheadedness, all are pretty much same. And thumping or racing of the heart is your palpitation. Your task is to take history from the patient, PEFE, ask investigation from examiner, and explain diagnosis to the patient. Any patient coming to you with a racing of the heart, the first investigation that you ask from the examiner is ECG. Okay, very, very important to ask it. If examiner gives you a ECG, you have to explain it to the examiner. The positive points in here, it could be like patient came to you with feeling palpitation and lightheadedness since 2 hours. Associated shortness of breath is there. There was previously 3 episodes which started suddenly, lasted 2 hours, and then stopped on its own. Patient also takes 6 to 8 cups of coffee a day. No smoking alcohol, no family history of heart disease. Patient also is a kind of anxious personality and has some stress in their life. So always remember, these are the differential cases. It's not that always one diagnosis will be in the question or in your hand. Sometimes you can have multiple diagnoses and you need to sort out what could be the most likely diagnosis, and then you should give differential diagnosis. Like in this case, they will give you a ECG of SVT. If ECG of SVT is there, your main diagnosis will be supraventricular tachycardia. And why is patient having supraventricular tachycardia? Most likely because of this excessive coffee intake, because that's one of the underlying cause. And then other could be a stress related, because this patient is having a stress. Also it could be generalized anxiety disorder, but as ECG showing SVT, so we don't think that anxiety is the only cause of palpitation in this patient. Now this is the important part. So you did the history. In the history you will get all these positive findings. After that, most of the time PEF is not important in these cases, so they don't ask it. They ask you to explain the ECG to the examiner. Now whenever they will give you an ECG, always try to look at the lead 2, because lead 2 is your rhythm disorder lead or rhythm lead. Now, because as you understand that if it was a ischemic heart disease or MI case, patient would come to you with a chest pain, not palpitation. So as palpitation is the cause or presentation of this patient is due to palpitation, so you should think that obviously there is some arrhythmia. That's why I have got the ECG here. Clear? So in your brain, these things should run. Otherwise, it will be difficult. Now look at the rhythm strip, which is the lead 2. Always when you look at the rhythm strip, see that what is the rate. Remember, I told you that if there is only one large square in between two RR interval, most of the time it should be, the rate should be 300. If two small square, rate is 150. In here you can see there is one large square and it's like two small square. So it will be like between, it's not totally 300. So it could be like 280, 270 like this. So just, you don't need to be exact with the rate, because they know that you don't have any calculator or anything. So just an approximate heart rate you have to comment on. So first thing you have to comment is the heart rate. After heart rate, then you need to see that rhythm. Rhythm, see that all the RR intervals are same, which means the rhythm is regular. After you have done with the heart rate and rhythm, then you start with the different component of the ECG. So first component of any ECG is the P wave. So this is normally P wave followed by QRS complex and followed by T wave, right? So this is the normal complex. So P, Q, R, S, T. So you have to comment on each of these wave and the different other components. So say that, what about the P wave? Now looking at this case, you can see there is no P wave. This is the T wave you can see. right? All these are T wave, but there is no P wave. So P wave is absent, and in supraventricular tachycardia, you will see that always it will be a narrow complex tachycardia, which means QRS complex will be very narrow, as you can see here, and rhythm will be regular, and there will be absence of P wave. So you can easily comment that there is no P wave. QRS complex is narrow. Normal QRS complex is in between 1 to 3 small square. Okay. In here, it's even less than 1 small square. So it's very narrow. So narrow QRS complex. After QRS, you have to comment on ST wave changes. There is no ST wave changes. So you can see there is no ST elevation or no ST depression. And then comment on T wave. T wave is normal incision shape. And last, what you comment on, QT interval. QT interval seems to be normal as well. So this is the Q, sorry. In here it will be, this one is the Q, and this is the end of the T wave. In here, like because it's a tachycardia, QT interval should be like, should get reduced. As you can see here, that's most likely 4, 5, 6, 7, 8, like kind of 8. So it's a normal, but sometimes it can be like reduced also, less than 8. So whatever you find, you can comment on it. In this case, QT interval is like baseline normal. Okay, so in here you will comment in this way. So you have to comment on P wave, QRS complex, ST wave, T wave, and QT interval. These 5 or 6 component you have to comment. Now looking at the case and looking at the rhythm strip, you will obviously understand that this is the supraventricular tachycardia. Supraventricular tachycardia, always there will be no P wave, rhythm will be regular, heart rate will be elevated, okay, and there will be narrow complex tachycardia. As you can see here, so this is a very typical ECG of SVT. Can you see any P wave? No, these are all T wave, right? So there is T wave, but no P wave. The rhythm is regular, heart rate is increased, okay, and this is narrow complex tachycardia. As you can see that it's even less than 1 small square. So when you explain ECG to the examiner, you have to say in this way. So, dear examiner, I would like to describe the 12-lead ECG of my patient, Mr. John, a 25-year-old gentleman who presented with sudden onset palpitation and giddiness. The ECG shows heart rate 150 or whatever you get it here. So heart rate 300 beat per minute or 280 beat per minute, regular in rhythm, absence of P wave, narrow QRS complex, no ST wave changes, T wave normal incision shape, QT interval normal as well. So I think that this patient is having supraventricular tachycardia. Clear everyone? Any question with this? So in this case, like as I say, Dr. Wafi, so whatever you will get it here, you can comment it. Most of the time, if it's a tachycardia like this, QT interval gets reduced. But you should always have a go with this first. So take a look and see that if the QT interval normal or not. But most of the time, if there is tachycardia like this, like 300 or 280 beat per minute, QRS complex should be reduced. But in here it's 7 or 8. So still if you say normal or reduced, it doesn't cause any trouble. So after you have explained the ECG to the examiner, then you explain this to the patient that what's exactly going on. So you will say that, well, thank you so much for your information and for your patience. John, as you can see, we have done a electrocardiogram of your heart, which records the electrical activity of your heart. According to that, most likely I am suspecting you are having a condition called supraventricular tachycardia. Or you can start in this way. Thank you so much, John, for your patience. From the history, physical examination, and the ECG, I'm suspecting you are having a condition called supraventricular tachycardia. Do you know what it is? No, doctor. Well, let me explain it to you. See that this is the electrical record of your heart, which we call ECG or electrocardiogram. This was taken when the nurse put those leads on your chest. And the lines, as you can see here, are the result of the electrical impulses conducted in your heart. Let me draw a picture. So you see that this is the heart. And the electrical impulses originate from here and then it goes all over your heart, and that helps your heart to pump the blood to your body. In your case, there is some abnormality in this electrical impulse, which causing your heart to beat faster than normal. And as your heart is beating faster, you are having this racing of your heart. And now, because your heart is racing, your heart is not getting enough time to fill, and that's why your brain is not getting enough blood. And there's a reason that why you are feeling giddiness or lightheadedness. Are you with me so far? Do you understand me? Yes, doctor. Now, there could be many reasons why you are having this sort of abnormal rhythm. It could be due to any structural heart disease. It could be any problem with the valve of your heart. Could be also related to some other conditions, like if you have endocrine or hormonal disturbance, like thyroid disorder, adrenal gland disorder, which we call Pheochromocytoma, or sometimes medication, recreational drug use, infection, salt and mineral imbalance can cause it. But in your case, I'm thinking because you are taking 6 or 8 cups of coffee a day, that must be the reason of your abnormal heart rhythm. Because I haven't found any risk factor of any other heart condition in yourself, and there is also no family history of heart disease. Okay, so always try to say that why exactly this patient is having palpitation, why exactly this patient is having lightheadedness, and then give the differential diagnosis. Okay, now do not go into the detail of ECG. Do not say this is P wave, this is ST wave, this is QRS complex. Don't go into that. That becomes very, very hard for the patient, and you may fail the case if you want to do these sort of things. Okay, so Always when you explain these sort of things to the patient, it's the same for most of the palpitation clusters, mainly for any arrhythmia. You can use the same format. Always say that what's the patient having, and then say that, see that this is the electrical record of your heart that we call ECG, which was taken when the nurse put those leads on your chest. The lines, as you can see here, are the result of the electrical impulses that conduct in your heart. Let me draw a picture. See that this is the heart. The electrical impulse start from here and then it goes all over your heart, and it helps your heart to squeeze the blood to the whole body. In your case, there is some abnormality in this electrical impulse causing your heart to beat faster than normal. That's why you are having this racing of your heart. As your heart is beating faster, it doesn't get enough time to fill in, so your brain is not getting enough blood, which is causing the lightheadedness or giddiness. Do you, do you understand me? Yes, doctor. There are many reasons why you can have this sort of abnormal heartbeat. But in your case, I'm suspecting it could be related to the excessive tea or coffee you are using. Other than that, it could be due to other reasons, like it could be any myocardial ischemia or ischemic heart disease, but you don't have any chest pain, your ECG doesn't go with the heart attack. It could be valvular heart disease, but unlikely because on examination I haven't got any murmur. Could be any medication induced, but you are not using any medication which can cause palpitation. Could be thyroid disorder, but you don't have any recent change of your weather or any change of your bowel habit or body weight. Could be infection, but you don't have any fever, cough, or any flu-like illness. So I'm suspecting that most likely you are having the supraventricular tachycardia. Don't worry, we are here to help you, and we can easily manage this problem or manage this condition with specific medications. Just finish there. If differential diagnosis is the case, then finish there. Most of the time, I have never seen management of SVT, management of AF comes in the exam. But just to give you an idea, any of this palpitation, management should be admission to the hospital, call your senior, because you are a junior house doctor or junior medical officer. In that case, you have to call your senior, and also you need to make sure that cardiologist review the patient. Okay, and after that, just we need to do some basic blood test for this patient, and we will do echocardiogram for this patient as well to find out if there is any underlying heart condition. But at the moment, if still patient is on SVT, the management depends on stability of the patient. If patient is vitally stable, mainly blood pressure is stable, and patient doesn't have any altered mental status, patient doesn't have any chest pain, in that situation, you can start the patient with vagal maneuver, which is like you can start with the vasovagal maneuver, or that means the vagal stimulation, immersion of the face in cold water. Okay, so any of or carotid sinus massage. So any of these you can start with. So you will just say at first we will try the vagal maneuver to stimulate one of the nerve in your neck, and that can reduce your heart rate, which we call vagal nerve stimulation or vagal stimulation. Okay, and then if that doesn't work, then we will start you with some medication called adenosine, or sometimes you can also start like verapamil, metoprolol. Those are less likely medication, but normally we will start with the adenosine. If patient is unstable, that patient will go for DC cardioversion. So obviously it should be done under the cardiologist supervision. That's most of the time management, but don't worry, management usually doesn't come for this sort of cases. Usually these are the DD cases. Dr. Tharinda asked, will the online Zoom exam allow us to use a pen and paper? Yes, this should allow you to use a pen and paper. The next condition is your atrial fibrillation. Any question on SBT, guys? Good. Now, atrial fibrillation will come with the similar kind of presentation, that means sudden onset of palpitation. And sometimes their task is like this: history, PEFE, investigation from examiner, explain causes and complication of the condition. That's a little bit of new task. So what could be the cause of this palpitation and what is the complication of your diagnosis? So in that case, in atrial fibrillation, the history will be totally same. That means patient will have palpitation, and also sometimes they can be totally young adult, or they can have sometimes underlying heart condition, especially hypertension, valvular disorder, or history of ischemic heart disease. So we'll try to find out, is there any structural heart condition that can lead to atrial fibrillation. Otherwise, the history is totally similar like your supraventricular tachycardia. Positive points was nothing, just positive was patient had hypertension. That's the only positive finding. Apart from that, others are all similar. When you ask for the ECG, they will give you the ECG like this. Now, again, look at the rhythm strip, what you can see. Now, you can see it's very hard to find out the rate of this condition. Now, for atrial fibrillation, don't bother with telling the rate, like exact heart rate here, because it will be difficult to calculate. Although we know how to calculate heart rate in atrial fibrillation, but for irregular rhythm, don't bother with that because it will just kill your time. So just skip it. Say that heart rate is increased, rhythm is irregular. Okay. So you can see that this is 1 RR interval, this is 1 RR. So it's irregular. You can see it's not same in every RR interval. So heart rate is increased, rhythm irregular. Now, can you find out the P wave? You can see we cannot find any specific P wave, but I can see there is T wave in here, okay, in here. T wave is there, but P wave is very hard because the P wave in here has been changed to fibrillatory wave. Okay, you can see fibrillatory means it's a kind of wave shape like this. So this is the fibrillatory F wave, not a P wave. So you will say, well, I cannot see any specific P wave, but I can see there are fibrillatory wave. QRS complex is normal. Okay, it's normal because it's one small square. You can say it's normal or narrowed. That doesn't make any difference. But atrial fibrillation, QRS complex is usually normal. So QRS complex is normal in size and shape. There is no ST wave changes. T wave seems to be normal in size and shape, and QT interval is normal or reduced, whatever you find here. So again, remember one thing: when you get a ECG of any patient, when the examiner gives it to you and you start reading the ECG, before that, just ask the examiner that, examiner, I would like to confirm that if this ECG is my patient, because sometimes it could be another patient ECG, right? So always say that, doctor, I would like to confirm that this ECG is my patient's ECG. Okay. So after you do that, then you start reading the ECG. These are all, Dr. Satha, these are all fibrillatory wave. You cannot say any of these are Q, any of these are P wave. Okay. This one you can see, this one you can see, these are all fibrillatory wave. Okay. In here, there are lots of fibrillatory wave, which we cannot even see. And just one or two, like sometimes one or two P wave can pop up like this one seems to be P wave, this one also P wave. Okay, like don't just get confused with those sort of things. Always in combination, what you feel, that's your main thing. And ECG is a kind of like a vast thing. It's really, really different for every patient, for every cases. So never ever just think that, well, I can see one P wave in here or in here. So it's not a atrial fibrillation. No, you have to always see the whole ECG, and then you have to come to a conclusion. All right, so explain the ECG in this way. Again, the similar way how we used to do. So say the heart rate is increased, irregular in rhythm, absent P wave, which is replaced by fibrillatory F wave, narrowed QRS complex or normal QRS complex. Whatever you will find out, you will just comment in that way. No ST wave changes, T wave normal in size and shape, QT interval normal or reduced. Explanation. So explain what's the condition. Explain that you are most likely you are having atrial fibrillation. Do you know what it is? Then you will explain just the same way of SVT, because the explanation is same. Atrial fibrillation also the same thing happened, that heart electrical impulses get faster. That's why heart beat faster. If heart beating faster, heart doesn't get enough time to fill in, so they can feel giddiness or lightheadedness because brain is not getting enough blood. Same explanation. See that how it's important to always follow a format. You don't need to memorize a lot. After you explain that, then you will say that, well, there could be many reasons of why you are having atrial fibrillation. What are the main causes of atrial fibrillation? Hypertension, ischemic heart disease or heart attacks, coronary artery disease, abnormal heart valve, or it could be congenital or the heart defects that you are born with, overactive thyroid gland, exposure to any stimulant, especially medication, caffeine, tobacco, or alcohol, sometimes previous heart surgery, recent viral infection, lung diseases can also lead to atrial fibrillation. But the most importantly, you have to talk about these 5 or 6. One of the other causes is called lone AF, in which there is no underlying cause. So you can also say that at the end. But hypertension, usually you will say high blood pressure, heart attack, or coronary artery syndrome, valvular heart disease or abnormal heart valves, heart defects that you are born with, which is the congenital heart disease, overactive thyroid gland, exposure to a stimulant, or sometimes it could be due to no underlying causes, which we call lone atrial fibrillation. But as they ask that what are the causes of the condition, you should talk about these things. The next option was complication. What is the most important two complication for AF? One is that you know that in atrial fibrillation, what happens that in the left atrium, because of excessive beating of the heart and turbulence of blood in here, patients start to develop thrombi in here. And that thrombi can dislodge, causing an embolism, and that can block your carotid artery. And then you can have a TIA or a stroke. So that's one of the very important complication. So in atrial fibrillation, the chaotic rhythm may cause the blood to pool in your heart upper chamber and form clot. And then if a blood clot form, it could dislodge from your heart and travel to your brain, causing blocking of the blood flow, which results in a stroke. And then also in atrial fibrillation, it can also weaken your heart and then lead to heart failure, in which your heart cannot circulate enough blood to meet your body's need. So complication is mainly these two, stroke and heart failure. Clear? So for your AMC exam, in case of palpitation cluster, if the ECG is your main problem, mainly SVT and atrial fibrillation is the case that is important. Other cases are not very important. So you don't need to go into that. Okay. And also another ECG we already discussed in the last session, which is your prolonged QT syndrome. That's not a palpitation cluster, that comes with a syncope cluster. So these three are mainly the ECG things that you need to know from rhythm disorders. Otherwise, we need to know about the chest pain, which is myocardial infarction and also pericarditis. Again, the management of these sort of cases doesn't come because it's very complicated and it's usually always done by a cardiologist. So normally AF SVT management doesn't come. The same thing will happen in here. Management will be depending on vitals of the patient. If patient is stable, then one thing. If unstable, then one thing. Unstable patient will go for DC cardioversion, which will be done under cardiologist supervision. If patient is stable, then always start with the rate limiting drugs if the patient heart rate is more than 100. So try with the beta blocker like metoprolol, atenolol, or also you can try with the rate limiting calcium channel blocker, which is your verapamil or diltiazem. And after that, some of this patient will also need anticoagulation. AF patient needing anticoagulation depends on the Chats-Vasc score. So you have to do a Chats-Vasc scoring on them. And if the Chats-Vasc score is more than equal 1, then only you will start the patient with heparin and warfarin. Okay, mainly not a heparin is not needed in this case. We will start with the warfarin in these patients. So that's why usually management will never ever come, because you need to do a whole range of things for this patient in the management. But just as a summary, if patient is stable, rate limiting drugs will be the first thing to start with. So beta blocker or calcium channel blocker. Rate limiting drug doesn't help, go with the rhythm related drugs. Mainly we start with the amiodarone, flecainide, sotalol, those medication. That doesn't help. The last option would be cardioversion. And for anticoagulation, you have to use that CHADS-VASc2 score, more than equal 1, go for warfarin. Okay, so that's your atrial fibrillation and SVT. Any question or any confusion so far? Start with the amiodarone. No question? We control rate first. Most of the time, rate control should be the first thing to try. Okay, now we move into the chest pain cluster. Very, very important for your exam. Okay, most of you will get questions from chest pain cluster because that's one of the very important cluster for your exam. So mainly you need to know about myocardial infarction, angina, and pericarditis. These three is your main important cases. But still, sometimes they comes with the differential diagnosis. So you need to have a very good idea on all these differential diagnoses. So what are the DD of chest pain? CVS is the most important. So it could be angina, could be myocardial infarction, pericarditis, aortic dissection, aortic stenosis. For lung, pneumonia, embolism, pneumothorax. For GIT, gastroesophageal reflux, peptic ulcer disease. Musculoskeletal, costochondritis, rib fracture. Neurological could be prolapsed disc in the thoracic vertebra causing referred pain in the chest. Herpes zoster can be psychological, panic attack, anxiety disorder. So see that there is a lot of system which can lead to chest pain. So when the differential diagnosis come, if you only ask heart-related causes, you may fail the case. Sometimes it could be just a case of gastroesophageal reflux. So you should be very careful in chest pain differential diagnosis cases because they don't actually allow you to make mistake here because these are vital things for a patient life. So CVS, lung, GIT, musculoskeletal, neurological, and psychological. Now we will go through the history and one by one all the questions for each of these cases. So in here, any patient coming to you with chest pain, the reassurance is very important because patient will feel like they are dying or patient will be very scared. So say that, hi, this is Dr. Ashan, one of the doctor here. I'm really sorry to know that you are having chest pain at the moment. Please don't worry. We are here to help you and you will be fine. Can you please tell me how severe is your pain in a scale of 1 to 10? Doctor, it's 10 by 10. I'm really sorry to hear that. I'm going to give you a strong painkiller right now so that you feel comfortable. Do you have any allergy to painkiller? Always before giving medications, ask the patient that does the patient has any allergy? That's a key step. If you miss that, you may fail that. And if you miss giving painkiller to a pain patient, you fail the case. Most likely, I'm not saying that you will obviously, but most likely your chances of passing that station goes very low. So these are the things they look that a patient is crying in pain and you are just asking questions without giving a painkiller first. That's not accepted. Okay, so always give the painkiller and ask that if the patient is having any allergy. So say that, can you please tell me how severe is your pain in a scale of 1 to 10? 10 by 10, doctor, or 8 by 10, doctor. Well, I'm really sorry to hear that. I'm going to give you a strong painkiller so that you feel comfortable. Do you have any allergy to any medication? No, doctor. Well, no worries. I'm going to give it to you. Now, some of these candidate I have seen because I have heard a lot of candidates role play like in these years. I know that how you guys make mistake or the how it looks bad or how the examiner will feel like why the candidate is doing like this. So always don't go to the nurse for giving a painkiller. I've seen that many of you do that. You say in here, well, I'm going to ask the nurse to give it to you. It's not needed. Or some of the candidates say that, examiner, I need to give painkiller to this patient. No, you don't need to say anything. You say that I'm going to arrange painkiller for you. By arranging, you are doing everything. That means you will obviously talk with the nurse, and nurse will give it to the patient. That's fine. But why I will waste my time by saying this sort of unnecessary thing? When I can just say, I'm going to arrange painkiller for you, you should feel fine after that. Say that and move on, because doing this painkiller and hemodynamic stability in the chest pain case will cost you 1 minute time. You will see that if you are not fast enough, it will take a lot of time to do these sort of things. So you arrange painkiller for the patient. After arranging painkiller, now also make sure you ask the examiner that if the patient is hemodynamically stable or not. So examiner, I would like to know if my patient vital is stable. Examiner says, well, yeah, you can proceed. Now, any patient having a chest pain, even if they're stable, your job is to hook this patient with the cardiac monitor, take the blood for cardiac enzymes, okay, and give the patient painkiller. And if oxygen saturation is low, then you give oxygen and Also, if it is a high risk chest pain case, you give aspirin to the patient. Remember that monotherapy is vital. If you get a patient, like, the scenario will help you to understand. A 45-year-old woman coming to you with a left-sided chest pain for the last 1 hour. That's your exam case. If you don't do the things that I am saying, these are actually, you are missing the key steps. All these patients should get a aspirin whenever they present. Most of the time, in the ambulance, they usually give the aspirin. But you have to, because in your exam there will be no ambulance, so you have to make sure that that patient get aspirin, because that aspirin can save the patient life. Clear? So you have to arrange those sort of things. So what you will say, you are going to the examiner for hemodynamic stability. Examiner say patient is hemodynamically stable, you can proceed. You will say, examiner, as my patient is 45-year-old and having a left-sided chest pain, I would like to hook, I would like to attach ECG monitor. I would like to attach ECG monitor, asking the nurse to take the blood for cardiac enzymes and give aspirin if it is not given so far. Clear? So that's your first thing to do. And then you come back to the patient and say, how are you feeling now? Are you able to answer a few of my questions? Yes, doctor. Can you please tell me more about the chest pain? When did it start? What exactly were you doing at that time? Now you are asking your Socrates question, pain question. Remember Socrates? I guess all of you has gone through those sort of things in your medical university. So that's your Socrates. In Socrates, you ask the site of the pain, where exactly is the pain, then onset. So what exactly were you doing at that time? How does the pain feel like? Now, character of the pain will give you most of the diagnosis. For MI patient, the pain will feel like pressure, tightness, okay, or heaviness in the left side. Whereas pericarditis pain, usually stabbing or sharp, like a sharp stabbing pain. Then radiation, does the pain go to anywhere? You don't ask, is your pain radiates to anywhere? Patient doesn't understand what is radiation. You have to say, does the pain go to anywhere? Associated, don't ask here. Okay. Timing or duration, also not important. You can say that, is it the first time you are having this sort of pain? And you should always ask that, when did the pain started? So when did the pain started? This timing or duration start at the first. Anything makes it better, anything makes it worse. That is your exacerbating or relieving factor. And severity, already you asked. So now go to here, you will say, when did it start? What exactly you were doing at that time? Did it start suddenly? Is it your first time? Is the chest pain continuous or on and off? Can you exactly point out where is the pain? Does the pain go to anywhere? Can you describe how does the pain feel like? Anything makes it better, anything makes it worse. Okay, now very important guys, like to ask this question. I have seen a lot of candidate, because the time is running, they are not asking properly this pain question. But this is important. At least, like, you can cut off continuous on and off if you are running out of time. Did it come suddenly? You can cut off, because you already asked that what exactly were you doing at that time. Okay, but site of the pain, then onset of the pain, the radiation of the pain, character of the pain, these are very important. If you don't ask it, it means that you don't know the basic history questions. So don't let the examiner understand that. Yes, aspirin before taking history. You don't need to say the aspirin dose. It's not important. You don't need to say that, but normally we give like 300 milligram aspirin, but no, we don't need to say how much you are going to give. Now, if you think, Dr. Iappa or any of you, that, well, if what if this patient is having aspirin contraindication, right? So in that sense, if you think that, what you can say, you can be more safe by saying that I would like to also give my patient aspirin, ruling out any contraindication to it. That make you more safer doctor. Okay, so anytime you feel like, well, what if this patient is having contraindication to aspirin, like peptic ulcer, right? Or patient having any bleeding from anywhere at the moment, and if I give aspirin, it can make it worse. So always say in that way, making sure that patient doesn't have any contraindication to it. That will cover you, and that will make you a more safer doctor. And believe me, examiners like those sort of things. Like you are asking allergy to the painkiller before giving that. So this makes you a safe doctor. And Australia wants safe doctor rather than a knowledgeable doctor. Okay, so you ask the pain questions. After those pain questions, then the associated. Always associated with the chest pain, there is shortness of breath, nausea, vomiting, excessive sweating, and racing of the heart. So along with the chest pain, are you having any shortness of breath, any racing of your heart, any nausea, vomiting, excessive sweating? That covers your most of the CVSDD, which means that it will cover your MI, ischemic heart disease, pericarditis will go with the chest pain. So you will see that how we are ruling out all the DDs. Now go to the differentials. For differential, start with the pericarditis, aortic stenosis, because ISD or MI already you asked. So for pericarditis, you can specifically ask that, does the pain get worse when you lie down, and does it get better when you lean forward? Any recent flu-like illness. Pericarditis patient will have a recent viral RTI history, and also they will sit in a way that they will show it to you that they are leaning forward to relieve the pain. So that's very important clue, that chest pain patient leaning forward, when they are when they are giving you the history, you should think that it could be a pericarditis case. Then for aortic stenosis, remember the triad: chest pain, shortness of breath, and syncope. So just one thing you are left with. So any dizziness or sudden blackout. You already asked chest pain, you already asked shortness of breath. That covers your CVS DD. Now the lung: pneumonia, pneumothorax, pulmonary embolism. For pneumonia, any fever, cough, shortness of breath. You already asked shortness of breath, so don't need to ask it again. Any fever, cough. For pneumothorax, any trauma to the chest. You can also ask any history of lung conditions. Pulmonary embolism, very important. Any recent travel to anywhere, any past history of clotting disorder, any family history of clotting disorder. For gastroesophageal reflux, does the pain has any relationship with food, any heartburn, or any bitter taste in your mouth? Patient with peptic ulcer or gastroesophageal reflux disorder, they will have the pain associated with the food, and also they will have a central burning chest pain, which get worse on lying down or bending forward. That's your reflux related pain. Or taking a spicy food, fatty food, hot fried food. Okay, so that's your gastroesophageal reflux. Then go to the musculoskeletal costochondritis. So is the chest sore to touch? Only costochondritis pain usually comes with chest tenderness. Other causes you will never ever get chest is tender. Only costochondritis or Tidges syndrome In that case, you will get soreness to the chest. Then neurological herpes zoster, any rash on your chest. Anxiety or panic disorder, are you generally an anxious person or do you worry a lot about most of the things? Any previous history of panic attack? Do you feel like you are having choking sensation or any fear of dying? Cool. So that's your differential diagnosis questions. Then just SADMA, family history, past medical history, and is the patient is on any kind of stress. So do you smoke or drink alcohol? Any use of recreational drugs? Any stress at your home or work? Any previous history of diabetes, high blood pressure, high cholesterol, or heart disease? Any family history of heart disease? Are you on any kind of medication? Always remember we finish the history with SADMA, past medical history, and family history. In SADMA, you have a smoking, alcohol, medication. Past medical history is the relevant for heart condition. These are the relevant past medical. Family history of heart disease is very important. And then you finish the history. So this is the format of any chest pain cases that can possibly come in your exam. So the initial step is important. What are the initial steps talked about? Giving a painkiller after ruling out patient doesn't have any allergy. Making sure my patient is hemodynamically stable. Making sure I offer the monotherapy if relevant. So morphine already you are giving by asking the painkiller. Oxygen only if the vital says that oxygen saturation is less than 94%. Nitroglycerin, also you can offer nitroglycerin to this patient who is having chest pain. And aspirin, very important to offer aspirin. Obviously, you will say that as my patient is a 45-year-old, high risk chest pain, I would like to attach ECG to my patient, take the blood for cardiac enzymes, and offer aspirin and nitroglycerin, making sure my patient doesn't have any contraindications to it. Clear? So this is how you should start. And then you start asking your questions. That's fine. If you give one dose of aspirin and your story ended like a musculoskeletal system or any other DD, that doesn't make you fail the case. Okay, because initially all chest pain is should be diagnosed as a MI unless proven otherwise. Any chest pain in elderly patient, mainly left-sided chest pain, not the right-sided, any left-sided chest pain or epigastric pain in a elderly patient should be regarded as a MI or heart attack unless proven otherwise. You give one dose of aspirin, that's fine. You are not continuing it. Okay. And PEFE, again, PEFE will be same like before. As I said, you can use only one format of PEFE for all cardiac cases. Now we will start with the cases. We have pericarditis, we have myocardial infarction, we have angina due to anemia, and we have CVS risk factor. We will discuss those cases after the break. So let's take a 10-minute break and then we will start. Thank you. All right, everyone. So let's start it again. So we discussed about the chest pain cluster, right? So we discussed about how you are going to take the history of chest pain. Now start with the pericarditis. So you've got a patient who is 50-year-old tram driver, presents with sudden onset of chest pain since 2 hours. Looking at this pain, there is no way you should think that this is a pericarditis unless you find it in your history and ECG. So you should think about that it's a myocardial infarction. You should start treatment like I said, and then when you will find out, no, this is not a MI case, this must be a pericarditis case, then you can stop your MI management. So you have to take a history, PE from examiner, diagnosis, and differential. Also, in these cases, they might give you some ECG in here, like with the stem, they can provide you a ECG also sometimes. Positive points that chest pain started since 2 hours, aggravated by lying down and deep breathing. That's a pleuritic chest pain. Like when any pain gets worse with deep breathing or inspiration, that's pleuritic chest pain. And that's not a presentation for myocardial infarction. Most of the time, it's pericarditis. Also aggravated by lying down, relieved by leaning forward. That's very important characteristic for pericarditis pain. It's a sharp stabbing pain. Sometimes it can radiate to the back and in between shoulder blades. Patient had a flu-like illness a week before, no other symptoms. So you have got a patient who's having a chest pain like this. Now you should think about, well, if there is a viral illness, patient doesn't have any other cardiac risk factors, and the chest pain characteristics is more going with the pericarditis, you should think about pericarditis as your diagnosis. And if you look at the ECG of pericarditis, you will find out any patient having chest pain, at that time, you should not look into the rhythm strip. You should look into the whole ECG looking for any ST elevation. So if you look at the pericarditis ECG, always start with the chest lead, which is your V1 to V6. In the chest lead, you can see V1 is not much important. V2, you can see. So this is the baseline, right? This is the baseline. This should be the baseline. Now, this is the P wave in here. Then QRS complex. This is the ST wave, right? The ST wave should be in here in the baseline, not above the baseline. When it's above the baseline, we call it ST elevation. Now, this is a characteristic concave shaped ST elevation. So concave shaped ST elevation usually not a presentation for MI. Rather, concave shaped ST elevation is more goes the pericarditis. So V2 you have got ST elevation, V3 again ST elevation, V4 you have got ST elevation, V5 ST elevation, V6 ST elevation. So there is widespread ST elevation in the chest lead. Then go to the lead 1. In the lead 1 again ST elevation. Lead 1 and AVL is lateral lead. So when you look at the lead 1, always look at lead AVL. Lead AVL, there is also a slight ST elevation. Lead 2, 3, and AVF. So these 3, 2, 3 AVF, these are inferior lead. Again, you see that lead 2 has a ST elevation, 3 doesn't have anything. AVF, very hard to say, but not much actually. But lead 2 has a ST elevation. Whenever there is most of the cardiac leads having ST elevation, you should think about pericarditis. Never ever in MI patient, all leads has ST elevation. One of the important things that you should always look in the ECG is that, remember, there is anterior MI, there is inferior MI. Anterior MI is your this chest lead ST elevation, like V1 to V6 anterior MI. If lead 1 and AVL, that's called lateral MI or high lateral MI. lead 2-3 AVF, inferior MI. No patient should have inferior and anterior MI together. It's very uncommon, can happen, but very uncommon. Okay, there is a term called reciprocal leads. Reciprocal leads means if any patient has ST elevation in the anterior leads, the reciprocal lead, which is your lead 2-3 AVF, that means the inferior lead is the reciprocal lead of anterior leads. They should have ST depression in case of MI. So again, let's assume that a patient has inferior MI who has ST elevation in lead 2, 3 and AVF. The reciprocal lead of inferior is your chest lead, which is V1 to V6. In V1 to V6, you should get ST depression, not elevation. When you get ST elevation in anterior lead and inferior lead, and all the ST elevations are mainly concave shaped or a kind of chair shaped, okay, it's kind of chair, someone can sit here, right? So that's mainly pericarditis. Is this clear for everyone? Remember in MI, when we will discuss the MI ECG, you should not get ST elevation in lead 2 and also in the lead V2, V3, VF. That's very unlikely in a MI patient. Reciprocal leads should have one lead will have ST elevation, another will be ST depression in case of myocardial infarction. But in here, you can see all the lead, that means most of the lead having a ST elevation. Whenever a patient has a widespread ST elevation in every lead, mainly every lead, but sometimes you may not get it in the every lead, most of the lead with a concavity upward ST elevation, like see, there's a typical concavity upward lead, then you should think about pericarditis. Clear, everyone? Any question or confusion? So when you get the ECG like that, and the pain also is a characteristic pain for pericarditis, then you can say that most likely you are having a condition called pericarditis. Do you know what it is? No, doctor. Well, let me draw a picture. So draw a picture of the heart and the pericardium and say it's a condition where there is inflammation of the outer layer of your heart called pericardium. Let me draw a picture. This is your heart. The outer layer of the heart is called pericardium. In your case, most likely it's related to the reaction of the viral infection that you had 1 week before. And that viral infection is also causing inflammation of the outer layer of your heart. And that's why you are having this stabbing kind of pain, which gets worse when you lie down and gets better when you lean forward. It could be due to other reason as well, like it could be myocardial infarction, but any myocardial infarction, your chest pain is not related to change of position like you are having. And also, typically it gets started in the left side and it goes to your left arm, neck and jaw with associated nausea, vomiting and excessive sweating. And also there should have a typical ECG finding as well sometimes. In your case, nothing is like that. So I can assure you that it's not a heart attack. But still, to confirm my diagnosis and to exclude heart attack, I would like to do some investigation and I would like to keep you under observation in the emergency department for a few hours. I will also call the senior and heart specialist who might do full blood examination, ECG, like means repeat ECG, and a troponin and a echocardiogram. When all these things are negative, then we can discharge you from the hospital with just some painkiller and just a bed rest. You should be fine within few days time. Okay, so that's your pericarditis management. Even if it's a pericarditis, obviously this patient should be admitted. Patient should have all the repeat ECG and troponin, and also if needed, the patient can have a echocardiogram as well. All this comes as a negative, then patient can go home And the main management of pericarditis is just bed rest, uh, symptomatic relief of pain by giving paracetamol and NSAID, and then usually within few days, 5 to 7 days, the pain usually gets better. Give 4 hour, that means you will again review the patient in 1 week time. And if any time you get a chest pain, which is left-sided, goes to your arm, neck and jaw, or goes to your back, and also you feel nauseous or vomiting, please call the ambulance immediately. I will give you the reading materials about all this I have talked. Okay, so this is the pericarditis management. We will discuss this reciprocal thing again in the MI, okay? And then you will understand that what I exactly mean. So look at this ECG. In this ECG, lead 1 AVL, which is the lateral lead, got a ST elevation. Lead 2 is the inferior lead that got ST elevation. Lead V1 to V6 is the anterior lead that also got ST elevation. Okay, anterolateral is mainly they are congruous with each other. That means there can be anterolateral MI, but there is never ever, not never ever, very unlikely to have a anterior MI with inferior MI. Okay, very unlikely, but can happen. That's why we say that if any patient having anterior MI, which means ST elevation in the V2, V3, V4, V6, any chest lead, that patient should have reciprocal ST depression in the inferior lead. So if it was a MI, the lead 2, 3 AVF should have ST depression rather than having a ST elevation. Acute MI. So 55-year-old man comes to your ED with sudden onset crushing chest pain. Take history, PEFE, investigation from examiner and explain, most likely cause and immediate management. In here again, it's the acute onset of severe chest pain, left-sided, crushing in nature, radiating to the jaw, neck, left arm, first time. Associated shortness of breath, nausea, and vomiting. There is positive smoking history, no previous heart disease. So the characteristic of the pain is very much going with the MI. So you should also think about MI in here. Obviously, as I said, in these sort of cases, you should follow that I would like to take my patient to the resuscitation cubicle, attach him on cardiac monitor, ask the nurse to do an ECG, will secure an IV line, take the blood for full blood and cardiac enzymes, start the patient on oxygen if needed. That is the perfect management for having any chest pain, which is a high risk chest pain like this patient. So take the patient to the resuscitation cubicle, attach him on cardiac monitor, take an ECG, secure an IV line, take the blood, send it for cardiac enzyme. And also offer aspirin and nitroglycerin after making sure patient doesn't have any contraindication to that. Now, the history will be same, PEFU will be same, but when you come to the ECG from the examiner will give it to you. And then you have chest pain, so you have to look in all these leads. You're looking for either ST depression or T wave inversion or ST elevation. Now look at lead V1. V1 having ST depression, right? This is the baseline, so it's ST depression. This is baseline, so ST depression in V2. V3 also ST depression, whereas V4, V5, V6, they are having ST elevation. Okay, now look at lead 2, 3 AVF. In lead 2, 3 AVF, we can see there is ST elevation, ST elevation, ST elevation. Lateral lead, lead 1 and AVL, pretty much same, but AVL having some ST depression. Now, ST elevation is in the lead 2-3 AVF. That means it's an inferior MI. Why? Because if you look at here, although this patient should not have V4, V5, V6 ST elevation, but looking in the all other leads, what is coming here is that this patient is having ST depression in the lateral lead, that is also a reciprocal lead, and mainly V1, V2, V3. These are also having ST depression. So ST depression in the anterior leads, lateral leads, but ST elevation in lead 2, 3 AVF, most likely it's the inferior AMI. Although I would say that most of the time this V4, V5, V6 should also have a ST depression, but in here it's not. There can be sometimes the sort of confusion, but always try to stick all the knowledge that you have got and try to come to a logic. The logic in this case is that this patient, if it was a pericarditis, lead 1 and AVL should have ST elevation, and all the V1 to V6 should have a ST elevation rather than ST depression. Okay, look at this one. In lead 1, no, always start with the chest lead. In V1, it's normal. V2, what you can see, this is the ST elevation, right? So there is a point called J point. You see that where the S wave finishes and T wave started, this point is called J point. This J point, if you look at, J point should be in the baseline in here. When it goes up, then it becomes a ST elevated or ST elevation MI. V3, again, see that this is the J point. So this is ST elevation. V4, you can see V4 you can see ST elevation, V5 ST elevation, V6 ST elevation. So most of the V2 to V6 has ST elevation. Then look at the 1 and AVL. 1 has ST elevation, AVL has ST elevation, right? Then the last one is to look at 2, 3 AVF. Lead 2, normal. Lead 3, having a ST depression a little bit. Lead AVF is normal, I would say. Okay. Now, you cannot say this one is pericarditis just because lead 2, 3 AVF doesn't have any ST elevation. Rather, it has in one lead, it has little ST depression. Clear? And also you can see some T inversion also. So when you get anterior MI, which is V1 to V6 ST elevation, also in here there is lateral MI as well, 1 and AVL has ST elevation. So that's called anterolateral MI. When you have anterolateral MI, your reciprocal lead is inferior lead. So 2, 3 AVF should not have ST elevation. It can be normal or depression. In full-blown ST elevation, it usually will go to the ST depression, but sometimes it can be normal like this. But it should never ever be ST elevation. Clear now, everyone? Also, this one is same. So after you have got it, you need to explain it to the examiner, right? So explain in the same way how I shown you that how you can explain ECG to the examiner. So comment on the rate, rhythm, and P wave, QRS complex. Now in here, ST wave elevation in which leads you have to comment. And then you have to say that it is the anterior MI, anterolateral MI, or inferior MI. Okay, anterior MI when there is only V1 to V6. If there is ST elevation, that's anterior MI. When with V1 to V6, there is lead 1 and AVL also has ST elevation, that becomes anterolateral MI. Inferior MI means lead 2, 3 AVF having a ST elevation. So, how you are going to manage? So, thank you so much for waiting, John. Now, based on the nature of your chest pain and according to the ECG, I'm really sorry to say, but I'm suspecting you are having acute myocardial infarction or heart attack. I'm really sorry. It's really a serious condition. In this condition, what happens is that the blood pipes that supplies your heart got blocked by some clots. And as a result of that, the muscles of your heart is not getting enough blood and oxygen, and it can lead to serious complication. And eventually it can cause death of your heart muscle. So in that time, you can draw a picture of the coronary arteries and show there is some clot and some part of the heart muscle is getting dead, right? So you can draw like this. You can draw here, there is a clot and this part of the heart is getting infarction. So say that I'm really sorry, but it's a serious condition. In this condition, the blood pipes that supplies your heart gets blocked by some clot. And as a result of that, your heart doesn't get enough oxygen and blood, and that can lead to serious complication and eventually death of the heart muscle. Please don't worry, you are in a safe hand and you are in hospital. It's very good that you have come early, and with proper intervention, we can manage any complication very effectively. At the moment, I need to admit you to the hospital, call my senior, and also call the cardiologist who will do further management. In the meantime, remember, if you forget to give aspirin initially, at this time at least give aspirin or Mona here. In the meantime, I have already started you with aspirin, which will help you to prevent this heart muscle dying. And also, I have given you a strong painkiller for your pain and will continue until you feel comfortable. I am also monitoring your heart rate, your oxygen saturation by this cardiac monitor. If your oxygen saturation goes below 94, we will also start you with oxygen. If you have ongoing chest pain, even after the painkiller, we can also give you a spray called nitroglycerin spray, which will relieve your chest pain. This is the immediate management, that means monotherapy. If you have already given it, already at least say that you have given it in the management. And then the specialist might do further investigation like basic blood test, ESR, CRP, kidney function, blood sugar level, lipid profile, and troponin. Very important is to say about the troponin. The definitive treatment of this condition is to remove the clot and restore the blood flow, what we call percutaneous coronary intervention or thrombolysis. This will be decided by the specialist based on the duration and severity of your condition. Once the specialist is here, also if needed, we will call the catheter lab to prepare for your PCI as soon as possible. But as I said, I'm just a junior doctor. This decision will be taken by the cardiologist. Okay, now if it's a acute MI, you don't need to talk about once you are discharged what you are going to do. Okay, you can finish here because already it will be a long station. You might not be able to come to this point. After you finish, after you say that you are sending the patient for PCI, then you can say that at the moment, once you once you are done with all this thrombolysis and PCI, we will refer you to your GP who will review you regularly. And also after the operation, we will put you on some medication like aspirin, beta blocker, ACE inhibitor, and statin. Also, we will advise you to adopt some healthy lifestyle to prevent any further heart attack. Okay, now remember one thing, the question is immediate management. Your immediate management means you say what the patient has got. That means patient has got myocardial infarction, and then you obviously reassure the patient because patient will be really scared by hearing that. and admit the patient, cardiologist, and you talk about the initial monotherapy, and always at least say about PCI because that's the most important management in this patient. So the definitive treatment will be to restore the blood flow by removing your clot either by percutaneous coronary intervention or thrombolysis. This will be decided by the specialist based on the duration and severity of your condition. Please don't worry. I understand that you might not be hoping any of this when you came here, but sometimes this thing can happen and this is not very uncommon. But you have come very early to us. We can do a lot of management and you will be fine without any possible complications. If you want me to call any of your friends or family member, I will be happy to do that. Okay, then finish the exam. Don't go to the detail of what you are going to do after patient has the PCA or thrombolysis. This is not very important at this time. Just finish with the reassurance. Yeah, oxygen is only based on saturation. Not every patient needs oxygen. Yeah, Dr. Anika. So it's a good thing because immediate management, you are just making sure that you are talking about the monotherapy. Just say that I have already started with you aspirin and a strong painkiller, and I'm also monitoring your oxygen. If you still having ongoing chest pain, I will give you nitroglycerin spray. This will help you with the chest pain. And in the meantime, also I have I will call my senior and the cardiologist, and most likely the cardiologist will go for the immediate coronary intervention, which is the percutaneous coronary intervention or thrombolysis. In that case, if decision is made on doing the PCI right now, I will also call the catheter lab to make sure that they start arranging it for you as soon as possible. Oxygen given if saturation is less than 94, not 92, 94. Okay, now the list go with the angina. You are a GP, 62-year-old male who presented a few days ago with chest discomfort. ECG was normal at that time. You have done a stress test which showed ST segment change in the anterolateral leads during exercise. And patient also had some chest tightness during the test. Patient is a smoker, no history of diabetes. Explain the test result with the patient, short-term and long-term management. Not very important for the exam, but again, it should be, at least you should know the management of stable or unstable angina. When a patient has normal ECG at rest, but when they do a stress test, that means they run on a treadmill, and during running in the treadmill, they have chest tightness or pain, and in the ECG, there is ST segment depression or T wave inversion. That means patient has a reversible ischemia. And those patient gets benefited from doing coronary angiography, and later on we can also offer coronary bypass or stenting for those patients. So that's the main thing that why we are doing the stress test for this patient. So explain first, so say that um, hi hi John, how you are doing. I hope that you have been doing great since we met last time. I understand you are here to know the results of the stress test that you have done few days back. How are you feeling now? Are you having any chest pain at the moment? No, doctor. Have you had any chest pain during this time? No. Okay, so I have already seen your test result, and based on your stress test, I'm suspecting the condition that you have got is called angina. Do you know what it is? No, doctor. Well, let me draw a picture. This is your heart. The angina is the name given to the chest pain or discomfort that comes from the heart when it is short of oxygen. So your heart is supplied by some blood pipes known as coronary arteries. And in this condition, these blood pipes get narrowed due to deposition of some fatty substances called clots. As a result of that, when you do some exercise, your heart cannot get enough oxygen, because you can say as a result of that, when you do some exercise, your heart needs more oxygen, but on the top of that, you are already having narrowed blood pipes, so your heart cannot provide enough oxygen and blood, and that's why you experience chest discomfort or pain during exercise. Are you with me so far? Yes, doctor. Well, please don't worry. This is a very common condition. Millions of people are suffering from this. But unfortunately, it can lead to serious complication called heart attack. And that's why it is very important to follow a healthy lifestyle to prevent any further progression of this condition. Regarding management, now this patient is having angina. Before you start management, it's better to do some investigation. What investigation you will offer? So you will say, as you are already been diagnosed with angina, I would like to do some investigation to see if you are having any risk factor. So I will do basic blood test, full blood, kidney function, liver function, your thyroid function, your blood sugar level, baseline ECG, lipid profile. Okay. Mainly the most important is doing a blood sugar level, lipid profile, and already you have done a stress test and ECG. That's the most important thing that you should do. And also try to ask couple of questions about the patient's lifestyle. Although history is not a component here, it's better to know if this patient having any heart risk factor. What are the risk factors? So I will just ask you a couple of questions to see that how is your lifestyle and how we can modify that. So do you do any kind of exercise? No, doctor. So do you take healthy balanced diet? No, doctor. And do you smoke or drink alcohol? Yes. Do you have any family history of heart disease? Yes. Do you have any other heart condition like high blood pressure, any previous history of heart attack? No. So that's mainly couple of risk factor question that you asked. And it will not bother examiner, but don't ask too many questions when history is not a task. But in this case, why we are asking? Because we need to manage this patient and we need to offer lifestyle modifications. So I need to know what's the lifestyle of this patient before I advise the patient. That's why I'm asking a couple of questions. So you did the investigations. After investigation, you ask 4 or 5 questions to find out the risk factor of the patient. Then you start with the management. So regarding the management, I will start you on some medication called aspirin, beta blocker, statin, and nitroglycerin. This is for every patient who is having a reversible ischemia. So aspirin, beta blocker, statin, GTL. Also, please try to take a healthy balance, healthy lifestyle. Cut down your alcohol to the safe level. Stop smoking if it is possible. Try to maintain ideal body weight. Do some exercise, ideally 30 minutes most of the days of the week. Take healthy balanced diet. Try to avoid stressful works. This lifestyle modification is for every patient. And for the further management, I will refer you to a cardiologist as soon as possible for further investigation. Most likely, you will be having a coronary angiogram. In coronary angiogram, they usually put you in sleep, and they then put a dye inside your vein, and that dye will go into your heart blood pipes, and it will show how much obstruction or narrowing of your heart pipes you are having. According to the angiogram result, next step of management will be decided by the cardiologist. They may put a stent to keep those narrowed arteries open, or if it is high grade block or obstruction, they can also offer you to do a open heart surgery. But it's all depend on the angiogram result and also you and your cardiologist decision. Are you with me so far? Do you have any question? Always in between your talking, try to engage the patient, because you are just talking and talking and talking. It becomes really boring. So always after 1 minute, just ask, how are you with me so far? Do you understand me? Do you have any confusion? Do you want me to repeat anything? So always ask it. Now, if any time, if you develop this sort of chest pain again, please follow the angina action plan. That plan is that if you have severe or prolonged pain after taking a rest, take the sublingual GTN tablet, or you can say take the nitroglycerin spray or the tablet under your tongue that I have prescribed. Wait for 5 minutes. If that doesn't relieve the chest pain, notify a friend or relative that you are having the pain. Repeat the dose after 5 minutes and wait for another 5 minutes. If still it's not relief, call ambulance, take a third dose, tell the ambulance that you are having a heart attack. So what you are doing, patient having prolonged chest pain and patient took rest, but still pain is there. So take one dose of GTN spray or tablet. Wait for 5 minutes, doesn't relieve, call a friend or relative that you are having chest pain and take another dose. Not relieved after 5 minutes, call the ambulance and say that you are having a heart attack, and also take the third dose at that time. Clear? And then I will give you reading materials. I will review you regularly once you see your specialist. So that's your mainly angina plan. No, you don't need to ask for cardiac enzymes in angina investigations, because patient is not having an heart attack or chest pain at this time. If your patient at this time having chest pain, then you can do it. But obviously this patient will not have chest pain now. They will come to you feeling comfortable, but you just need to explain the stress test. So angina, you should explain what it is. After that, you should explain why it's serious. You should order some investigation and then ask some history to find out the risk factor. Then management, those medication, beta blocker, statin, aspirin, and GTN spray, and adopt healthy lifestyle. The very important step is to send the patient to the cardiologist, and possibly cardiac angiogram will be done. And depending on that, further management will be tailored. And lastly, give the angina action plan. Any question, guys? Yeah, GP can prescribe those medication. Cool. Let's say there is another case called angina due to anemia. This case is a little different from the cases that we are doing from the MI perspective. So see that a 50-year-old man is in your GP clinic complaining of chest pain and dizziness for the last 1 month. Now, it's been going on for the last 1 month. For chronic chest pain, you don't need to do all those hemodynamic stability or giving aspirin monotherapy, not needed, because this is going on for the last 1 month. So this patient having chest pain, dizziness for the last 1 month. For chronic chest pain, always think about there should have some underlying disorder causing this angina. The positive point in this case, Patient having on and off chest pain, which is not very severe, 5 or 6 by 10, constricting, retrosternal, comes and goes, precipitated by effort, relieved by rest. Also, sometimes it's radiate to the neck, jaw, and arm, which means that it's a cardiac pain, right? Then also having dizziness, especially patient feel dizzy when standing from sitting or lying position. What does it mean? It means patient having some postural drop, right? So patient feeling dizziness, also tiredness when standing from sitting to lying position. Then patient is a smoker for the last 15 years. Alcohol intake is also there. Cholesterol normal, healthy diet, no medication, no history of heart conditions. Physical examination is normal. Patient looks pale. Whenever you get pale, you should think about, well, it could be anemia, which is causing the chest pain. BP 180 by 80, sorry, 120 by 80 when the patient is sitting position, but when they stand up, it's 105 by 80. So there is some postural drop also, although it's not very significant, but there is some postural drop. Pulse rate 90, regular. All other examination is normal, but in this case, see that you have got blood on DRE, which means patient might be losing blood from the GI tract. This is the only case when you should think about that checking for a DRE in the abdominal examination. Other cases, we don't need to actually go with this abdomen and DRE when the patient come to you with acute severe chest pain. This is a chronic chest pain. Chronic chest pain comes and goes. Usually it could be related to some loosening of blood. So from where the elderly patient lose blood, mainly from GIT. So you should do the abdominal examination and followed by DRE. In history, in here, you will offer painkiller if the patient wants, otherwise no need. Ask the all chest pain question, ask the dizziness question. So can you please tell me more about the dizziness you are having? Have you ever fall or lost your consciousness? Any relationship with change of your position from sitting to standing position? Then you will get, yes, doctor, I feel more dizzy when I change position. Associated symptoms like shortness of breath, nausea, vomiting, racing of your heart. So all those similar questions. Differential diagnosis will be, everything will be same. So you have to ask all the DD for chest pain, but there is a DD anemia. When you come to the anemia DD, then you have to go in detail of that. So why this patient having anemia, you have to find out. So do you feel tired and weak these days? Yes, doctor. When you get a yes, that means you go into the detail of anemia. For anemia, main things we need to find out is if there is any dietary deficiency of iron or nutrition, if the patient losing blood from anywhere, is the patient taking any medication that can cause occult bleeding in the GI tract. So can you please tell me, do you take healthy balanced diet? Yes. Have you noticed any change in your bowel motion? Any change in the color of your stool or urine? Color of the stool is important, that if the patient is having any black stool or not. Any loss of weight, loss of appetite, because most of the time anemia in elderly patient having like iron deficiency anemia, we should think about any cancer, mainly cancer colon. So loss of weight, loss of appetite important, change in bowel motion important, and change in color of the stool is important. Any history of heartburn or indigestion, that means sometimes peptic ulcer disease can cause anemia. Then any past medical history, especially any peptic ulcer disease, any family history, SADMA. In the SADMA, most important to find out if this patient is on any NSAID for any back pain or anything. Okay, so these are the important thing you will look for in this case. So for this particular case, you have to ask all the anemia question. So you have to find out why this patient having anemia. Is it diet induced? Is it cancer? Is it loss of blood from anywhere? Is it related to peptic ulcer or medication? In the PFE, general appearance, pickled pallor is very important. Vitals and BMI. If patient having cancer, their BMI can be low. Then also severe same. In here, your abdomen is important. You have to ask specifically for DRE, for any blood. Then respiratory system, office test BSL, urine dipstick, and ECG. Now, when you ask the vitals, what is the important thing you should ask here? For postural blood pressure. Because patient having dizziness. Any patient having dizziness, always in the vitals, ask postural blood pressure. Now, you explain. So from the history and examination, most likely you are having a condition called angina due to anemia. Do you know what it could be? No, doctor. Well, let me break the term for you. Anemia means lack of blood in your body, which most likely could be due to lack of dietary intake or loss of blood from your body. In your case, when I did the rectal examination, I found some blood in my globes. So most likely you are losing some blood from your back passes. And due to lack of blood supply, your heart is not getting enough blood and oxygen, which is causing a stress on your heart. And that's the reason you are having on and off chest pain, which we call angina. Right now, I need to admit you to the hospital because you might need some fluids. Also, I will call my senior and you will be seen by a gastroenterologist and the cardiologist for further investigation and management. So in here, because this is a angina, cardiologist should be involved. Also, bowel specialist, which is the gastroenterologist, should be involved because patient is losing blood from the back passes. Further investigation will be done. It could be full blood examination is important to know the anemia level, ESR CRP, ECG, iron studies, blood grouping and cross matching, liver function, kidney function, and blood sugar level and cardiac enzymes. If the patient having chest pain at the moment, then you do the cardiac enzymes, otherwise not very important. So very important investigation in here is to do the full blood examination and iron studies. With that, obviously blood grouping, cross matching, kidney function, liver function, and doing a ECG. Also, specialists might also consider doing endoscopy and colonoscopy to find out the cause of the loss of blood from your gut. In endoscopy and colonoscopy, it's a procedure in which you will be under sleep, you will not feel any pain. They will pass a flexible tube inside your mouth to look into your stomach for any cause of bleeding. Also, a flexible tube will be passed through your back passes to look into the gut, to look for any suspicious changes or any cause of bleeding. Please don't worry. As I said, you will be under sleep and you will not feel anything. Also, we need to stabilize your condition and manage you according to the cause. Once the cause is found out, you will be managed accordingly. Okay, so for anemia causing angina, in here is not mainly related to the heart management. The management is finding out the cause of the anemia, because if you can treat the anemia, the chest pain or angina will also be improved. Clear? So mainly you should offer this endoscopy, colonoscopy, which mainly will be done by the gastroenterologist, and they will obviously find out some cause, and according to the cause, further management will be done. Is this clear for everyone? Any question for angina due to anemia? Now, today we will finish here. We just have one case left. which I don't think is a good idea to start now, because I think most of you are really, really having some headache because lots of cases we have discussed today. So the next session we will have cardiology role play. Before we start the role play, we will do that case, and then all of you who are in the class try to join our role play session. We will ask someone of you to come forward and do the role play with us. We will do all the past 1 year important cases, and we will do role play on those cases. Okay. What do you mean by that, Dr. Wafi? I haven't understand. Are you going to be teaching all the topics? In the cardiology, there are no other cases, most likely. We already discussed most of the topics. There is only one topic which we are left with, which is the CVS risk assessment, which we will finish in the next class first. And after doing that, we will do the role play. We usually finish the theory first, and after doing the theory, we do the role play on all these cases, which is important in the past 1 year. And if anytime if we miss something in the theory, we can also discuss it during our role play session. Yes, yes, Dr. Wafi, we will teach every topics. As you know, our course is a 5 months course. This is just the 2 weeks free session. After 2 weeks free session, those who join our course, we will teach everything like pediatrics, medicine, surgery, psychology, whatever important for your exam, we will finish everything. Okay. Thank you everyone for joining these sessions. I hope this will help you to understand how we take our session. And if anyone wants to join the course, still we are taking the students into the course because the seats are very limited. So if anyone wants to join, try to contact our team through the email or the messenger so that we can at least keep the seats for you so that you can get the opportunity to continue with us for the 5 months. And it's a Dr. Wafi, we don't take class one to one. It's a session of like 20 or 25 students. It's a kind of online class, and we take the class just like how we are taking class now. But in your course, there will be no Facebook live. The course will be only on Zoom. Yes, we give recordings for every class just after, like within 1 hour, within 24 hours of the class, the recordings are usually uploaded in our software. You can easily get the recordings and listen to it if you miss it. And Dr. Amjad, so all the time, remember, clinical exam is not only just question solvation, it's mainly we discuss everything which can come for this particular topic. Like for cardiology, if you know these clusters, like syncope cluster, palpitation cluster, chest pain cluster, there should not be any case left which can appear in the exam. So sometimes it can be there, like in some other topics like respiratory or any pediatrics classes, we might miss some random cases which doesn't fall in any cluster. For that reason, we keep the role play session where we find out if we have missed any important cases. and we try to do role play on those cases so that we can finish it. In that way, there should not be any important cases left for your exam. We should finish everything, but we will see throughout the 5 months. If you guys are coming into our course, then you will see that how we can help you. And anyone having any confusion regarding the course, or want to know anything, feel free to ask to our team members through the email. They are always working through the email and trying to answer your queries. So you can obviously ask it in the messenger also, and sometimes also email, whatever you prefer. Thank you all. So we'll see you in the next class. I think already all of you has got the class schedule. So just join the class just like you are doing now. Thank you all. Have a good night. Bye.